All right, let's go ahead and get started. My name is Dr. Karrie Hohn, and I am a functional medicine provider here at Palm Health. Like I said, we are going to talk about metabolic syndrome today. It is one of my favorite topics. It's near and dear to me, to my practice, to my entire family. So let me see if I can make these slides work, and then we'll get started. Okay, so I want everybody to know what metabolic syndrome is. I want them to know how to identify it in themselves, in those around them, because if we identify it early enough, we can treat it. And if we can treat it, we can arrest current disease. We can prevent future disease, diseases like high blood pressure, diabetes, obesity, and cardiovascular disease. There are several terms that are used for metabolic syndrome. Syndrome X is one that you may hear. Insulin Resistance syndrome is another that you may hear. They're all referring to the same thing. So just so that we know, anytime you hear that from a medical provider or in the media, those are all the same, meaning different names for the same thing. All right, so what is metabolic syndrome? So the National Cholesterol Education Program identifies metabolic syndrome as an individual who has any three of the following issues. One, if it's a woman and her waist circumference is greater than 35, or a man with a waist circumference greater than 40. I had a patient that I saw this morning, and I noticed he had a little bit of a belly, but absolutely ideal weight. And you never would have thought of this man as being a candidate for metabolic syndrome, but he did have a waist circumference of 40. You never would have guessed it, and I wouldn't have unless I checked his waist. So that's one criteria. Another is a criteria of high blood pressure. So a blood pressure, a systolic over 130, a diastolic over 85. Or if a patient is already on blood pressure medication. Another criteria is a high fasting blood sugar, one that's 100 or greater. The other two markers have to do with cholesterol, and they are the elevated triglyceride greater than 150 and an HDL cholesterol that is less than 50 for a woman and less than 40 for a man. So interestingly, about 6 years ago, I myself qualified for metabolic syndrome. I was a young mom. I was working a part-time job, but working full-time, taking care of little kids, super busy husband. And I realized that somehow my pants wouldn't snap like I like them to. And it was at that same time that our office required we have blood work done. Every year we had to check our cholesterol. We had to fill out paperwork just to go over what was happening with our health, which in hindsight is a very good idea. Every year I would fill out the paperwork and I would answer, how many times do you eat healthy foods? How many times do you? And I was like, yeah, I do it. How many times do you eat fast food, processed food, junk food? And I kept saying, yes, yes, yes. Every year, year after year, I was eating too much of that. And I kept checking those papers. And every year I thought about it. But it was this year when I had my blood drawn. The very same day, I had the blood work done of a patient of mine that I was seeing, and he happened to be an over-the-road truck driver. So I ran down, got my blood drawn, came back, saw the patient, got his blood drawn, and our labs came back a few days later. And what I noticed was that his labs, the over-the-road truck driver, had better labs than I did. That was really, it was upsetting to me. I know this guy probably eats on the roadside, at fast food restaurants. And I realized that I'd been working pretty hard to take care of myself. I was trying to get some exercise. I was eating a healthy breakfast. I was eating a healthy lunch. Everybody made fun of the smells coming out of the microwave when I would heat up my lunch brought from home. We would have, healthy dinners with lots of veggies. But what I was doing in addition to that was having a big cookie after lunch. I was having a margarita maybe when we went out to dinner, and I was having some ice cream at sometimes, far too often before bed. And so what happened was these things were adding up. And I remember even at that time talking to my staff and saying, well, you know what, I have the 95-5 protocol where I eat 95% fantastic food and then I eat 5% junk. And what I found out at that point on that day when I got those labs back was that it wasn't working for me. I was working really hard, but I wasn't achieving goals. I was not able to lose that last 25 pounds. I had an elevated fasting blood sugar, which really scared me. I had high cholesterol, triglycerides, and a low HDL. And my waist circumference was enlarging. So these are things that I decided at that point I wanted to make some changes. And so I did. I listened to those around me who had been talking about this functional medicine thing. My big brother, who's a physician, he's the one who really lit the fire and said, hey, why don't you think about? And so I started looking into functional medicine, and I started to employ it for myself, changing my diet, changing my lifestyle. And I started to look for metabolic syndrome in my patients because I realized if it could happen to me, it could happen to anyone. So how do we do this in primary care? How do we help somebody like me? How do we identify it? I know I never would have identified it in myself if I hadn't gotten my blood drawn, and if I hadn't had to answer those questions every year, and if they didn't measure my waist every year with my previous employer. So we have to ask. So in primary care, we can check weight, we can check body mass index, and we can check waist circumference. And those are basic things that any primary care provider can do. So this is a body mass index. So, and I realize I have a lot of patients who, and I myself, when I look at my own waist size, I'm like, oh no, you kind of don't want to know the answer. If you look at your weight, you kind of don't want to know the answer. And I know that it can be upsetting, but I think knowing our height and our weight and our body mass index is a really fantastic tool, and it can help us make changes. It certainly did for me. So if we imagine that we are talking with a patient who is 5.9 or 5 feet 9 inches, if their body mass index is 18, meaning they weigh 120 pounds, that's going to be a weight that's too low. And this is not metabolic syndrome when the weight is too low. When individuals have a weight that's too low, they can have fatigue, insomnia, anxiety. They can get sick more often. Women can have trouble having periods and have osteoporosis issues. So it's important not to be underweight. For this individual, 5'9", weighing 130 up to the 160s, that's a healthy weight. That's a weight where the best health is found. If that individual at 5'9" weighed 170 up to, under 200 pounds, that would be overweight. Once we hit 200 up to 260s, we're in the category of obesity. And beyond that, we're in the category of severe obesity. So we really do want to be in this green section as much as possible. The green section in terms of height for weight, the calculation is your weight in kilograms over your height in meters squared. That's how we get that body mass index. But if we're in the green zone, we are more likely to be healthy. If we're outside of the green zone in the yellow, orange, or red zone, we're much more likely to have metabolic syndrome. We're much more likely to have illnesses associated with metabolic syndrome. So another tool that we use that's very simple in primary care functional medicine is the tape measure. So again, for women, if they have a waist that's greater than 35 inches, or for men, a waist that's greater than 40 inches, it's something that we want to take a look at. We want to pay attention to it. Some individuals carry their weight in their abdomen. We call this visceral adipose tissue. Viscera are the contents of the abdominal cavity, and the adipose tissue is the fat that surrounds those organs and is actually inside of those organs. So these are people like my granddad who had a nice, big, tight belly. It's for people like me 6 years ago who had a pudgy belly, but I had this extra several inches around. So this is called android or apple-shaped figure, or android obesity. Other individuals tend to store their fat not in the abdomen, but they store it in what we call the subcutaneous tissue under the skin. And they tend to store it around the buttocks and the hips. And this is known as gynecoid obesity, or having a pear-shaped figure. So individuals with this pear-shaped figure tend to have more issues just by looking at a patient. I can say they probably are going to have more issues with hormone problems, gut issues, and detox issues. Individuals with this VAT or visceral adipose tissue, belly fat, are going to have more issues statistically with metabolic syndrome. So that's how we measure here at PALM. We take a look at our patients, looking at their height and their weight and their waist circumference, but then we get fancy because we're PALM. And we do what we call a body composition analysis. So every year at the annual preventative visit, we encourage our patients, and we don't, of course you don't have to, but I think it is interesting. We have them stand on the device and a current travels through them from their feet to their hands, and it assesses their body composition. So it tells us what's happening with their hydration status. Where's the fluid in the body? Is it in the cells or is it outside of the cells? It tells us about fat mass. It tells us about lean body or muscle bone mass. It tells us about basal metabolic rate. So really, really interesting. And I think it's surprising. I've had patients who really came back elated and said, well, I have more muscle than I thought I did. Or they come back and say, oh, I thought I had some more muscle, but turns out I have more fat. So, the ratio is really important. And it's not just the weight that we're looking at entirely. It has to do with the how the body is composed and what that weight is made up of. Other signs of metabolic syndrome we find on the lipid panel, like I mentioned earlier. This individual has one marker. These triglycerides are elevated at greater than 150. I had several markers out of whack when I did my testing 6 years ago. So individuals that have abnormal cholesterol panels can either have dyslipidemia or they can have hyperlipidemia. But again, this is another marker that helps us diagnose metabolic syndrome. So why are we so worried about metabolic syndrome? Well, what we found out is that the metabolic syndrome is the root cause behind many illnesses. So cardiovascular disease starts with this excess belly fat. Cardiovascular disease means stroke and heart attack, or peripheral vascular disease, or kidney dysfunction. Lots of things can happen. High cholesterol can happen with metabolic syndrome. High blood pressure. Erectile dysfunction is a sequelae or consequence of metabolic syndrome, as is polycystic ovary, cognitive decline or Alzheimer's, osteoporosis. There's non-alcoholic fatty liver disease. And really what happens is the liver fills with fat. There's fat around the liver and there's fat in the liver. Obesity, of course, is a sequelae of metabolic syndrome. Sleep apnea, sarcopenia, which is a relative muscle loss, meaning individuals with a larger abdomen who tend to store fat here tend to have less muscle mass in their body. And then also type 2 diabetes is a result of metabolic syndrome. So I always want to know why. And I think knowing the why is really important, because once we know why, then we can start to answer, well, how do we fix it and how do we stop it? So what happens when there is intra-abdominal or that visceral adipose fat, the fat stored, the belly fat, it causes insulin resistance and inflammation. And that leads to elevated blood pressure, elevated blood sugar, and also abnormal cholesterol panel. And this is where it gets a little tricky, but I think it's really important to pay attention and understand the connection. The insulin level, let me go back to that slide. The insulin resistance happens, and insulin resistance happens because of the abdominal obesity. You see these flames, that's inflammation. So those two things are happening when there's fat in the belly. And this belly fat isn't just sitting there minding its own business. It's causing all sorts of mayhem. So insulin helps glucose move from the bloodstream into the cells. So when we eat something, it's absorbed into our gastrointestinal system. It goes to our bloodstream, and suppose there's glucose in the bloodstream, the insulin is what allows that glucose to get from the bloodstream into the cell. Once it's in the cell, it can be converted into energy in the form of ATP. What happens though is we eat too much, the cookie, the margarita, and we end up having too much glucose in our blood, and we end up storing too much glucose in our cells. And what happens when we store too much is that it eventually gets turned to fat because our body can't use it. So it stores it to fat, kind of long-term storage until it's needed. What happens when we store this belly fat is that it creates an insulin resistance. So in the case of the belly fat, the insulin resistance, the insulin goes to the cell, tries to encourage the cell to let the glucose in, but the cell is resistant. It's harder for the cell to respond to insulin to bring the glucose in. So what happens is the blood sugar glucose level goes up, and then the body responds and says, well, there's a lot of sugar in the blood, so I'm going to put out more insulin. And as the body puts out more and more insulin, there is more fat storage that occurs. And when there's more fat storage, there's more insulin resistance. And then we have this ever increasing fat storage, blood glucose, high insulin level issue happening. So it is a vicious cycle. And that is what metabolic syndrome is. That's what insulin resistance. Insulin resistance is a huge part of metabolic syndrome. So it all starts with excess glucose, excess fat, insulin, and it just keeps going and going. It can be very difficult to break that cycle. I've heard medical providers describe it as a fat trap. So what causes the insulin dysfunction? So at some point, individuals go from normal insulin function over to insulin resistance. So what things lead to that? So poor lifestyle. The lifestyle that I was leading 6 years ago, working a lot and eating on the fly and eating too many sweets, that was a poor lifestyle. If we have a lifestyle where we're not active, that can lead to insulin resistance. If we have mitochondrial dysfunction, mitochondria are the little powerhouses in our cell that help us make energy. If they're not working properly, we're more likely to get insulin resistance. If our gut bacteria is off balance, we are more likely to get insulin resistance. So this tells us it's not only how much we eat, but it's what we eat. So we want to fill our diet with colorful fruits and vegetables, lots of vegetables, so that we can balance our gut bacteria and not develop the insulin resistance. Then there's altered body composition. So back to the body composition analysis. If we have much, if our ratio of fat is too high, a body fat versus our lean body mass, that can be an issue that can lead to insulin resistance. So all of these things from altered body composition up are modifiable. There's things that we can do about them. We can change our diet, our lifestyle, our exercise to modify those. This last one, the genetic predisposition, there's nothing that we can do to fix that. So in my family, I come from, 2 parents with Alzheimer's, a dad with diabetes and heart disease, a brother with heart disease. So I've got the genetic predisposition to be diabetic and have heart disease, but I'm doing all of these other things to prevent that from happening. And what we're finding out more in functional medicine is the genetics are just a part of it. There may be 10% of it, but our lifestyle is 90 to 95% of our outcomes. So we really we have ability to respond. We have a responsibility to make changes. And that's luckily what I was able to do 6 years ago, is to make those changes. I'm no longer insulin resistant. I'm no longer pre-diabetic because I was able to make those changes. So what does insulin dysfunction cause? So remember, we've got that belly fat and we've got the inflammation, and it's not just sitting there, it's causing mayhem. It's setting us up for all kinds of medical problems, for obesity, for sarcopenia, a loss of muscle mass, fatty liver disease, diabetes, cardiovascular disease, stroke and heart attack are a result of insulin dysfunction. Also, hormone imbalance is a result of insulin dysfunction. So we can have endocrine dominance, pardon me, estrogen dominance. We can have endocrine cancers like breast cancer and ovarian cancer. We can have polycystic ovaries. We can have osteoporosis. So many things happen, and it all starts many times with this insulin resistance, leading to lots of medical illnesses that perhaps could be avoided. Okay, so this is a really sticky slide, but I think it's important, and I will try to use a dark Sharpie marker to explain. Imagine if, like Karrie 6 years ago, I ate that big cookie and then later went out for a margarita, and then I maybe had ice cream before bed. And I can't say that that never did happen on one day. I imagine it might have. So I've got glucose and lipotoxicity. I've got too much sugar coming in and too much fat coming in. So initially, I was a lean person, and then I started to gain weight. And as I gained weight, you can see these fat cells. They're called adipocytes or fat cells. They start to get bigger than they were, and they start to get become more in number. They also have these little immune cells, these macrophage immune cells that are drawn to the area. As we become obese, we have a marked enlargement of our fat cells, and we even have death of these fat cells. So inside this abdominal cavity, we have these cells that are dying. They're splitting open and kind of spilling their contents, which causes a lot of inflammation and irritation. And these little cells, these immune cells, put out inflammatory chemicals called cytokines. Kind of like saying, hey, they're like the cops at the scene of the crime. They're trying to fix things, but in trying to fix it, they might make it a little bit worse. And so what happens is, in that intestinal or in that abdominal fat, we get inflammation. We also develop that insulin resistance right there. And then it spreads throughout the body. It spreads through the blood vessels to places like the liver. So this top box over here is looking at the liver and how our liver can actually become filled with fat. So, you know, when you have too many things at your house, you start, you know, like I have more clothes, and so I start putting some in, you know, my girls are at college, I start putting clothes in their closet. That's what's happening here. The body doesn't know what to do with the fat, so it starts storing it all over the place. So it's got these fat cells that it's storing in the liver, and then the inflammatory cells are also in the liver. And the liver has a job to do. It's supposed to be detoxing and protecting our body, but it can't do its job very well if it's full of fat and it has these inflammatory chemicals in it. And so what happens is we can end up with, you know, a buildup of toxins and an inability to detox because we have what we call, you know, fat-filled liver or fatty liver. We also can have fat that travels to the muscles. So instead of having nice, you know, strong muscle cells, we can end up having muscle cells that are replaced with fat cells and inflamed muscles. So guess what? We might have muscle weakness and we might have muscle fatigue because there's inflammation in our muscles and there's fat. And we might also have discomfort. We might just ache all over. That can be part of what's happening with insulin resistance. So not only do we have fat stored in the liver and in the muscle cells, but we also have inflammation there. But the muscle and fat cells, the muscle cells, fat cells, and liver cells become insulin resistant. So when the body sends blood to the liver and glucose is in there and the liver wants to use it because it needs energy, it's hard to do that because it's insulin resistance. So we can have liver dysfunction, liver failure because of that. Same thing happens with our muscles. The body sends blood with glucose in it to the muscles, but they can't use it. They can't get the glucose out of the blood into the cells to be turned into energy because of the insulin resistance. So it's very interesting. All of this starts with eating a bit too much and storing a bit too much fat, and then all this crazy inflammation that comes from it. So metabolic syndrome is at the heart of it. Here's another complicated slide, but not too bad. So we have this same little nugget of fat that's living in the abdominal cavity, and we have these inflammatory cells, and they're producing these inflammatory markers that spreads from the fat cells into the blood vessels and goes to the liver. And those inflammatory cells cause the liver to increase the blood sugar, not what we needed, cause us to increase insulin, not what we needed, and increase the triglycerides, definitely not what we needed. It also causes inflammation of the blood vessels. So there's extra fat because all those fat cells have broken and now they're being absorbed and sent through the blood. We have these free fatty acids that are in the blood. We have the inflammation, and all that causes irritation in the blood vessel wall. That's called endothelial dysfunction, and it can make the vessel wall stiff over time and can cause high blood pressure. So that's the why. That's what's happening. That's the beginning of what's happening with metabolic syndrome and insulin resistance. And if it goes on for long enough, we can create these plaques inside of our vessels and inflammation in the vessels. And what happens, this endothelial dysfunction, or the lining of the vessels being inflamed, if that goes on for long enough, we can end up having a narrowing of the vessels so that we don't get blood supply to certain areas, like our brain. So little mini strokes in the brain. We can have a narrowing of blood supply to our feet, having what we call peripheral vascular disease or poor circulation. We can also have these plaques that rupture suddenly, and they cause a clot, which stops blood flow suddenly, and that can cause a major stroke or major heart attack. So insulin resistance, metabolic syndrome are at the root of all of these illnesses. And if we think about it, our blood vessels travel to the whole body. So our kidney we can have kidney failure because we don't get good blood supply. We can have problems with our eyes because we don't get good blood supply. And guess who? Metabolic syndrome is at the root of it all. So I think we know what it looks like when we see someone walking by, and we might be able to recognize it in someone else or ourselves. We know the simple tools to use to figure out our height, our weight, our body mass index, our body composition. Next step is doing blood work to see, do we in fact have metabolic syndrome? So these are some should know laboratory tests. And the very first thing, obviously the body mass index, the waist circumference. We also check the blood sugar, and we check a fasting insulin. And 6 years ago, I was practicing primary care, and now I'm on the functional medicine side. Back then, I only checked, I didn't check insulin, actually. I gave insulin, as a prescription, but I wasn't ordering insulin testing, very rarely. I order it much more frequently now because it is an early marker of metabolic syndrome. We check the hemoglobin A1C, which is the 3-month marker of blood sugar. We also check the cholesterol panel or lipoprotein profile. And we do, there's the standard tests that I showed you before, the total cholesterol, the LDL, triglyceride, and HDL. But in functional medicine, we do a lot more. We want to know more about those numbers, and we want to drill down a bit. We check highly sensitive C-reactive protein, and that can be a marker of very low-grade inflammation. That inflammation that we see, that endothelial dysfunction, will light up this test. It'll give us a clue that something's inflamed. The abdominal cavity with the fat cells, certainly we know the inflammation is there, but it's a sign of, yes, there's inflammation going on and we're not headed in a healthy direction. We also check blood count. We look at platelets. We look at homocysteine, GGT, B12, magnesium, vitamin D. We look at the liver function, of course, and many times we're checking the urine to see if there's protein spilling into the urine. All right. So as usual in functional medicine, we kind of have the basic testing, and those basic tests and the basic exam, we can probably make a diagnosis of metabolic syndrome. But in functional medicine, we take it a step further so that we can not only identify it, we want to put some handles on it and say, now how can we treat that? What if we do a little bit more testing and it gives us some clues? So we want to make sure the waist to hip ratio, we want to check the circumference of the hips and the waist. That's important. We want to do that body composition. We want to look at the thyroid, consider celiac disease. We want to look at other vessel inflammatory markers, because that gives us a clue. That tells us, how bad is this? How far down the line are we with this? So these give us a great idea. IgE, ferritin, fibrinogen, other insulin and glucose testing we can do. We do check some genetics here, because sometimes when we get a genetic result, it will guide our therapy recommendations. It might give us an idea, what might benefit one person as compared to another based on their genetics. Some individuals, if we think they may have heavy metal exposure in their lifetime, we may do metal testing as well. And that's definitely something we do not do in primary care. So functional medicine, and that can be very beneficial, because sometimes heavy metal toxic exposure can be at the root of, and it can be the thing that makes it very difficult to treat metabolic syndrome. Okay, I love this slide because it shows us kind of how it works. So this is, imagine an individual who, the natural history of diabetes, they've received a diagnosis of diabetes here on day 0. If we were to take a look back in their chart, we would notice that 5 years ago, they were actually diabetic 5 years before their diagnosis in some instances. So this can happen because the primary care doctor is not screening for diabetes. It can be that the patient is not seeing a primary care doctor regularly, or it could be that they're seeing the primary care doctor, but for a sinus infection or an ankle sprain, and they're never getting down to the health maintenance of height, weight, waist circumference, and blood work. So it's important that we start to look for these things. What's really important on this slide is right here. This is the insulin secretion. So 10 years before a diagnosis of diabetes, we see this insulin level going up, 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 up. And so in any patient that I suspect may have metabolic syndrome, we're going to check the insulin and check for insulin resistance. See if that level, we know it's going up. The body's making a lot of it because the body can't respond. So it has to make more and more to get a response. So that's, if we can go back here and we can make some lifestyle changes back here, that's where we can really prevent things like diabetes and vascular complications like stroke and heart attack. This is where I was. So maybe I would be diabetic by now if I hadn't made some changes. All right, this is a cool slide, and it explains if you've had a functional medicine advanced lipid panel, you'll notice that it's not just those 4 markers, but there are a bunch of other markers. So we check the total cholesterol, the triglyceride, the HDL, and the LDL. So in this example, here's the LDL. All of these patients have an LDL. Jerry, Susan, whoever they are, David and Maria, they all have an LDL cholesterol of 125. But you'll notice that they have different particle size and particle number. So in the advanced lipid panel that we do, the Cardio IQ or the Boston Heart Test, we're looking at the particle number, not just how much total LDL cholesterol they have, but are they big LDL particles or are they little LDL particles? These little particles can do damage in the bloodstream. And I use this example. I was driving down the road with my sons from baseball, and my son said, "Mom, here comes a golf ball down the highway toward us." And there was this ball bouncing toward us. And he was really excited, thought it was great. And I was like, "Well, great, we're about to crash and have a broken window." Turned out it was a wad of paper. So it was nice and soft and fluffy, like these large LDL. These smaller LDL, lots of particles, are hard. They're dense and they're small, and they can irritate the walls of the vessel. They can damage the walls of the vessels and cause a lot of trouble. So there's much less risk when somebody has these large, fluffy LDL particles and a smaller number of them versus an individual over here who has lots of particles and they're very small and dangerous. So a benefit of functional medicine to help us. And I have patients who have normal cholesterol levels. Those first four numbers are normal. So their primary doctor would have said, hey, you're doing great. But when we look at their particle number, they're not. And so I can tell that person, hey, it looks like you may be headed toward a problem. Let's make some diet and lifestyle changes and see if we can avoid a future problem. So I think that's pretty darn cool that we have that ability. Okay, here's the genetic testing I was talking about. And this particular example is ApoE. It is a gene that we each have. We get one allele copy from our mother and one from our father, and we can have combinations. And so the most dangerous combinations over here, the 3-4 combination and the 4-4 combination. There's other types that are, lower risk. Individuals in this category are more likely to have vessel wall disease and plaque formation and stroke and heart attack. Interestingly, these individuals respond very well to a low-fat diet and avoidance of alcohol. So individuals that have this marker, we know we can definitely make some big changes. Low-fat diet isn't for everyone, but for this patient, it would be. Other testing that we do, we test MTHFR, which is a methylation detox marker. Individuals that have a methylation problem, an MTHFR problem, can have trouble detoxing, and they can have elevated homocysteine levels, which are inflammatory. We can treat those individuals with B vitamins, and we can have them eat a ton of green leafy vegetables, and we can lower their risk in that regard. So genetics don't tell us everything, but they give us some clues that can be really helpful, in terms of management and disease prevention. Alrighty, so now we know what it looks like walking in. We know what the labs look like. How do we treat it? My theory is, and has always been, and I think the longer I practice medicine, I remember as a med student saying, okay, what's the drug? I know what the problem is, but what's the drug? But every time we learned about a medical illness, they would say, okay, the first thing we want to do is diet, lifestyle, exercise. And I'm like, blah, 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 what's the drug? And what I've come back to the longer I practice medicine is that is the drug. A healthy lifestyle, healthy exercise is more powerful than any pill that we can take, any supplement that we can take. So we can be much healthier, and it can be more important than our genetics if we take good care of ourselves. So if we focus on sleep, diet, exercise, and stress reduction, we can do a lot. And I've had patients who come to the office. I had a patient back in my old practice, 5 years ago, who was diabetic and then suddenly was diet controlled within 3 months and had dropped his numbers in half. And I said, what did you do? And I said, well, was it the medicine that we started? He goes, I didn't start it. Was it this medicine? I didn't start it. What did you do? He changed his lifestyle. He listened to what we were talking about and said, you know what, I'm going to do that. And I said, well, why don't you do these things, but let's start some medicine, and then we can take them off later. And he knew himself and did it himself. Was very powerful. And I've seen that again and again and again. Lifestyle is much more important than supplement or medicine. That's not to say you should stop your medicine, but it can be very, very powerful. All right, so sleep is really important. I remember learning about sleep as a functional medicine provider and realizing, wow, I've got the license to sleep. It's not a weakness, and you're not being a baby if you sleep. Sleep is very important. So make it a priority. Good quality sleep, it heals the body. Try to get 8 hours each night. If you snore, please check into it. See a pulmonologist. Have your sleep apnea test done. And if you have sleep apnea, treat it with a device or treat it with a CPAP machine. If you have insomnia, speak to your doctor about treating your insomnia to improve your sleep. Sleep is important. And if we don't treat sleep, it's really difficult to reverse the situation in metabolic syndrome. It's very hard to lose weight if we're not sleeping. Of course, we are what we eat. And I will say what we drink. I remember, I don't know, maybe 15 years ago, I realized, there's calories in what I just drank, whether it's milk or tea or soda or the margarita. So water, tea, and coffee are usually pretty safe as long as you don't junk them up and add to them. So for my patients who have metabolic syndrome, I recommend the Institute for Functional Medicine has a cardiometabolic diet. And so just a quick summary, this is not meant to be the whole thing, but with the cardiometabolic diet, I recommend that we get 3 full meals per day that are healthy, non-processed, and balanced. And think about the plate. I always say, think about your plate, and I always say, where's my protein? Am I getting 20 grams of protein at breakfast, at lunch, at dinner? That equals about 60 grams of protein per day. And getting protein is important because if we're not getting protein, we're not going to build muscle. If we're not building muscle, we're not going to make strong bones. If we're not going to build muscle, we're not going to burn fat. So muscle is huge. And the amount of muscle that we have in our midlife projects greatly how healthy we are going forward. So we really want to build up that muscle. Don't eat, crazy amounts of protein, but, low ball numbers, 60 is probably as low as you want to go for protein. So make sure you're at least getting 20 grams. So meat, fish, or chicken, the size of a deck of cards, 3 eggs, 3 tablespoons of nut butter, 20 grams of protein powder. At each plate, try to put 2 to 3 servings of vegetables on your plate. And I will say I wasn't doing this. I remember what I was eating when I started the whole process, and it wasn't a vegetable at breakfast. Now I have a smoothie most days, and on the weekends I have a sit-down breakfast with vegetables. But try to cover half of your plate or half of your smoothie, more than half of your smoothie, with vegetables. A serving is about a cup if it's raw or a half a cup if it's cooked. And then try to get all the colors of the rainbow. The more colors that you have, the better. Try to get those root veggies, the ones that grow beneath the ground, like kale, rutabaga, turnips, beets, those guys. They are just wonderful for the gut and the gut bacteria. Also have 1 small serving of fat for every meal. So olive oil, coconut oil, nuts, or seeds. That fat, that omega-3 fat balance is so important for our system, for all the cells of our body to function well. In addition to those 3 full meals, eat 2 servings of fruit per day, either fresh or frozen. Again, very colorful. And then about a half cup of cooked grains or a small slice of bread once or twice a day. And make those the whole grains, the quinoa, the brown rice, steel cut oats type thing. Make sure you're getting your 64 ounces of water, and think about fasting overnight. Think about the circadian rhythm, eating when the sun is out and not eating when the sun is down. So after dinner, give yourself a 12-hour break where the body rests and digests. It's not a diet. It's just not eating all the time. And I think we've been accustomed to having food everywhere all the time. So I think it's a step back and maybe a healthy step to maybe kind of where I didn't grow up with food all the time. So, and I don't think most of us did. So important to take that 12-hour break for the body, let that body rest. And our insulin level typically does not rise when we're not putting stuff in. So that lowers the insulin level as well. All right, exercise. We're going to make sure that we're getting plenty of good exercise. So U.S. Department of Health and Human Services recommends the following physical activity guidelines. So moderate intensity activity, 150 minutes a week, minimum of 10 minutes at a time. So you got to have at least 10 minutes at a time for it to count. Or you can do vigorous activity for 75 minutes a week, and pick one of the top 2, and strength training twice weekly. So it's important to be active. Cut down on the sitting, get up and do golf or yoga, ride a bike, play tennis, and then do all these everyday activities like use the stairs, rake the leaves, mow the lawn, take a walk, walk to lunch, have a walking meeting, whatever you can to be more active each day. How do you know if it's high intensity or low intensity? First of all, you can calculate it. You can use this heart rate monitoring to check it, or you can just do what I do and make sure you're huffing and puffing. So if you can sing while you're exercising, it's low intensity. If you can talk but not sing, it's moderate. And if it's difficult to talk, if you really can't talk or you don't want to talk, then it's vigorous. Alrighty, and this just shows the benefits of exercise. So you notice that if you're sedentary, there's not a lot of benefit. If you're doing high intensity interval training, you're going to get improvement of your lipids, blood pressure, glucose, insulin, and body composition. Walking hits 3 of those, yoga hits 3 of those, resistance training hits 3 of those. So bottom line, be active. Stress is huge. I think we like to stay stressed, be stressed, and be busy. And now that we're coming out of COVID, there's more cars on the road. Everybody's going to meetings. We're getting back on planes. Check your stress. Make sure that stress is being managed, because stress can cause all kinds of problems. So when we're stressed, our sympathetic tone is up, our fight, flight, or freeze is up, our parasympathetic is down, our rest and digest is down, the balance is off. And when that balance is off, we can blood clot easier. We can have more coagulation. So if you've got the vessels that are full of plaque and full of endothelial dysfunction, you're more likely to coagulate or clot when you're stressed. So reducing stress is important. It increases our blood pressure, our weight, our insulin resistance, our cholesterol, our heart rate, our blood pressure. Also causes growth of tumor being stressed. So really, really interesting how stress impacts our life. What can we do about it? You can set up healthy boundaries, eliminate unnecessary activities, do things that nourish your mind, heart, and soul, like prayer, meditation, yoga, Epsom salt bath, cryotherapy, sauna, salt room, cardiac coherence, massage, acupuncture, counseling. The guys with the stars are the ones that are available at home. And if you remember, take advantage of these. I can tell you, I feel so rejuvenated after the salt room. I come out of cryotherapy and I just feel just this amazing feeling, hard to describe, like a total reset. So if you remember, use these things. If you're not a member, try to do all the free things that you can, like prayer, meditation, yoga, Epsom salt bath. I just bought a bag for $3.59 the other day. These are all things that we can do. So it doesn't have to be fancy, but it can. But bottom line, reduce stress. All right, and there are some supplements that we can consider. I always like someone to be on a healthy multivitamin, a good quality, because we want to bolster what it is we've eaten and kind of round up the edges and make sure we might not be perfect eater every day, but we want to make sure that we're getting nutrients. Vitamin D, it's important to check a level and treat. Fish oil is fantastic to boost our omega-3s. So eat fish, take fish oil. I think it's very basic, very anti-inflammatory. Magnesium is lovely. It's a cofactor nutrient that is used all over the body for many things. Caution with magnesium, if you take too much, you can get diarrhea, so be careful. CoQ10 helps with lots of things, especially with making ATP or energy in our mitochondria. So good to have enough CoQ10. Alpha lipoic acid, lovely for diabetics, pre-diabetics, peripheral neuropathy. It's shown to be beneficial. Other supplements to the right, the chromium, vanadium, biotin, C, zinc, and selenium. Also wonderful to help with metabolic syndrome. All right, so now you know what it is, you know how to look at it, you know how to identify it, you know what to talk to your provider about, and now you know what to do in terms of how to treat it. So just very important that we do treat it, that we can make changes now to arrest, prevent, all kinds of major illnesses. So thanks for your attention. Thanks for listening. And I wish you the very best health. Thank you.